All right, well, we'll go ahead and get started. We'll let people continue to come in during our introduction. Welcome, everybody, to the HTRC Education Series. I'm Molly Brown, the Director of the Heartland Telehealth Resource Center, and we're glad you're joining us today for this webinar. This session is being recorded, and we'll share it with you afterwards. Your microphones have been muted upon entering the rooms, so please unmute or use the chat to talk. Your completion certificates will be emailed following the webinar today. It's important to sign on with your first and last name so we can identify you. You can rename yourself by using the 3 dots up in the upper right hand corner of your screen to change your name. So let's get started. I'd like to introduce Richelle Marting. Richelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have Richelle with us today to talk about evaluating your reimbursement billing process. I will kick it off with an overview of the HTRC eStart assessment and then turn it over to Richelle. The Heartland Telehealth Resource Center is one of 12 regional and 2 national resource centers supported by funding from the Health Resources and Services Administration. HTRC funding supports building and enhancing telehealth programs in our region, Kansas, Oklahoma, and Missouri. As part of our work, we provide technical assistance to telehealth programs, which could arise from your attendance at one of our outreach and education events, like our education series, or from resources you may have accessed as you began your program. There are many ways we can provide this assistance, and one of those is through evaluation. Next slide. The eStart assessment is a thorough evaluation of your telehealth program and involves coordinating your telehealth team, engaging stakeholders, and reviewing data. Areas we focus on in this assessment includes your current state, needs within your health system, readiness, planning and implementation, community engagement, and billing and funding. For our webinar today, Richelle will be focusing on evaluating and assessing your billing and funding processes, giving tips and tools to prepare your organization not only for the upcoming end of the public health emergency flexibilities, but also to plan for sustainability. So we'll go ahead and get started and turn it over to Richelle.
Right, thank you, Molly. So we had 3 parts to this session today, at least for my part, going through a couple of things, looking at your billing processes, health kind of from start to finish, and looking at what the different pieces of the billing process are. I hope throughout the session, I'm able to give you some practical kind of checklist items as takeaways that you can go back to your organization, regardless of what type of healthcare provider or facility you are, and use these to do sort of a health assessment on where you stand today, plan, look at gaps, look for improvement, and then that sustainability piece that Molly mentioned. I always try to start these out with any late and breaking news that's happening in the world of telehealth. And one that you may have seen in the last week or 2 is an announcement of a federal bill that has been introduced by the House to Congress, proposing to end the national health, the national public emergency early, before the May 11th date that we've been planning on. And I wanted to emphasize for this group that if you see that announcement, there are actually two emergency declarations that remain. There is a national emergency that's declared by Congress. There is a public health emergency, what we call the PHE, though, and that we're all concerned about winding down, that impacts a lot of our telehealth flexibilities. The one that's been introduced to end is the national emergency, not the PHE. I guess let me back up and say that again. The one that has been introduced to end early before the May 11th date is the national emergency, not the PHE. It would not impact the May 11th expiration of the public health emergency that we've talked about in the last several sessions. So I wanted to share that because when you first read the announcement, it's a little bit alarming and confusing about whether we may be looking at an earlier end date to the PHE, and that's not the case. So with that, I'm going to switch gears to the actual topic of today's session, evaluating the health and sustainability of your billing process. I liken this to a wellness check for your revenue cycle, kind of a head to toe, start to finish assessment on all of the different steps in the process. What's involved in those steps, where there's some common pitfalls, and some questions that you can ask yourself or that you can look into for your own processes to see if there may be gaps and opportunities for improvement. Because in this revenue cycle, the whole concept with sustainability is making sure that we have steps in place at each phase in the process to ensure there's a way to document and to bill and to code and be paid for the services that we're providing as best that we can. So I want to kind of talk about those steps first, and then we're going to dive into each one in a little bit more detail. So I've got my patient in here, or in this case, the revenue cycle is coming in for this head to toe, start to finish assessment. And I think of it in chronological order. So one of the preliminary steps is a patient calling or going online to book an appointment. That's the stage when we're collecting some of the preliminary demographic information about the patient, name, date of birth, maybe some preliminary insurance information, chief complaint, reason for visit, and those types of things. We have the check-in process, and that's kind of for your in-person brick and mortar type service, or in the telehealth setting, that could be the login process where we actually start the visit or the encounter with the patient. Rendering the service, documenting the services that are rendered in a complete and compliant way. After the service are rendered, we're trying to capture the charges of everything that was done during that visit or during that encounter or during that stay. Taking those charges that we've captured, those services that have been performed, and then translating them into the billing entry or the data entry process, whether that's automatic through your electronic system or whether that's a manual process of keying in charges. That's what's happening at the billing entry step. Once we get the charges entered and coded, they're going to go out the door, and they are likely to go through a healthcare clearinghouse, kind of a scrubber, to look at the procedure codes and the diagnosis codes and the units of service to see if that patient is in the payer's system and eligible on that particular date of service and covered under their health plan, which could result in claims getting rejected or sent back to the provider to fix, or could cause them to go on to the payer, accepted into the payer's claims processing system, where they go through another round of edits and reviews that could then lead to payment or a denial that comes back to the provider or the healthcare facility to review. Hopefully, though, we're getting paid in that process. And when and if we get paid, we're going to post those payments to the system and look for things like, did you get paid the amount that you expected? Was there a denial? If there's a denial, that's not a payment amount we would expect. And we'll talk about some things you can look at in this process at payment posting. Once we've kind of resolved any denials, any rejections, appeals, we've posted payment and got paid what we expect from the insurance companies or other third-party payers, then we may be transferring any balances to patient responsibility. And there's some steps that we want to think about in that process. So head to toe, start to finish in chronological order, those are the things we're going to be assessing about the revenue cycle and the billing process. So I'm going to start with that very first step, the piece of scheduling. Whether this is a phone call, whether this is online, there are several ways that you can assess what you're doing in this process, standardize it, and help prevent some common errors that prevent you from ultimately getting paid for the services later on. So of course, at this stage, we're trying to figure out who is calling or who's logging in, who it is scheduling the appointment. For pediatric cases, when I'm doing this for my children, if I'm able to do this online or I'm making a phone call, I'm often asked, what's your relationship to the patient? Are you a parent? Are you a guardian? Are you a grandparent? That's trying to get information about whether the person scheduling the appointment for someone else has the authority to consent to the appointment or consent to treatment and so on. We're collecting information about the patient themselves. So patient name, date of birth, social security number, so a lot of that basic demographic data to sort of create an account if this is the new patient, or to look that patient up in the system and make sure all the demographic information is still current and still correct in the system. Because particularly insurance information at this stage, when it's time to submit that claim, we want to make sure all of that remains accurate so that we don't have a rejection or a denial. Contact information, particularly for new patients, making sure the phone number is still accurate. If you send out paperwork, and I say paperwork, whether that's hard copy paperwork or electronic paperwork, if that's going out electronically or via paper, we want to make sure we've got an updated address on file, including an email address, if that's the way we send electronic pre-registration paperwork to the patient. So we're validating all of that information is for a new patient is entered, or established patients are reviewed and updated. Now, if we're going to be communicating with the patients electronically, even in the pre-registration paperwork process, this is always a great stage to ask or confirm if they are okay with those electronic communications. So maybe at the stage when you're asking about the patient's address, you're collecting an email address, a good email address on file, this would be a great time to communicate what types of things may be going to that email address. Enrollment in the patient portal, maybe bills or statements, your pre-visit paperwork, again, hard copy or electronic, and giving the patient the opportunity to say, yes, this is the best email address for that type of communication. I'll give you an example of that. In our family, we have a shared family email address that we use for things like school, doctor's appointments, and so on. But maybe if there's a particularly sensitive topic that I'm signing up for an appointment or getting an appointment for, I may have a different email address that I might want that to go to that's not our shared family email address. Gives the patient the opportunity to get that updated for this particular service. Getting information on the health plan, as we know, this can change frequently, particularly with employers changing their employer-sponsored health plan payer pretty often, whether that's actually changing from an Aetna to a Blue Cross or a Cigna, or within those payers, changing to a different health plan year to year. That seems to have more movement now year to year than it used to in the past, and happens more frequently. So we want to make sure we're getting their updated insurance company, plan, member ID, group number, if we've got that, the claim address or information on the back of the insurance card. Scheduling is a great time to do that. You might also ask the patient, depending on whether they're coming in for their visit or whether they may be doing this virtually, how you're able to get a copy, a visual of that insurance card, or if they're going to be asked to put that in through the pre-registration process, like electronic forms and paperwork to fill out. This is also a great stage to let the patient know if that health plan is one that you are not in network with, one that you don't participate with. If you don't have a list of your health, not only the insurance companies, but the plans and products underneath those companies that you participate with, publicly available, this would be great scripting to let your schedulers know to educate the patient and say we are in or out of network. If they are out of network, that may have higher cost sharing and financial responsibility. You may want to have policies about the amount that the patient may be asked to pay upfront or at the time of service if they are out of network with their insurance company. Depending on your provider type, you may have price transparency and fee estimate responsibilities if you are out of network with the patient's plan or product. And again, it's just great education. If you say we participate with, I'll just throw out United Healthcare as an example, but United Healthcare has 10 products. most people wouldn't know that you could participate in some, but not all of those products, thinking simply participating in United Healthcare is a blanket across the board participation. If this is going to be a visit, a stay, anything related to telehealth, scheduling is a great time to ask the patient where they will be located at the time of the appointment. So once you confirm the date and time that will work, you can ask, will you be located in the state of Kansas, in the state of Missouri, in the state of Oklahoma? That helps you from a licensing standpoint to make sure that you've asked the patient that question and the provider that the patient is going to be having that visit with is licensed in the state where they will be located at the time of service. Asking about the chief complaint. Why are you scheduling the appointment? When you go to some of the larger chains that offer telehealth services and you can schedule your appointment online, you can see sort of a triage where they ask you the types of complaints or concerns that you may have. And it sort of delineates that which ones may be appropriate for a telehealth visit versus conditions or complaints that would be ineligible for a telehealth visit. This is a great time to have a checklist or a decision tree for schedulers to help them discern when it may be appropriate to do a telehealth visit versus when an in-person visit may be needed. Some examples of that may help delineate whether the particular service is appropriate for telehealth or not could be services like a wellness visit. First, just like any wellness visit, we want to see if the member is still within, how do I say that? Not still within, outside of their benefit plan coverage. Have they had a wellness visit in the last year? If it's been less than a year, we may let them know we've got to bump this appointment out to make sure that it's covered from a frequency perspective. We know that some telehealth services are limited in frequency as well, in terms of how often we can have a telehealth service. We may need to look at those coverage restrictions. Complaints as to whether the nature of the complaint, is it something that's appropriate via telehealth, or does it really need to be an in-person visit so the provider can have eyes and ears and hands-on with the patient for a physical examination? Potentially patients who may be seen for controlled substance prescriptions, and this is more so after the public health emergency ends, and the RHIA and HTRC Act that I know quite a few of you have asked about throughout the public health emergency, that typically requires an in-person visit before controlled substances could be prescribed via telehealth. During the PHE, that flexibility was waived, and you've asked what happens after the PHE to that flexibility. Beyond the scope of today's session, there is a proposed rule out there from the DEA on how they would handle that after the PHE ends, but that's something to look at in terms of scheduling, depending on the time frame and when the appointment is, before or after the PHE. If prescription renewal is part of the visit or an intended part of the visit, if those prescriptions may involve controlled substances, is that something that's appropriate via telehealth versus needing to be in person? So here's some checklist items you can think about in the scheduling process to help kind of assess where you are today versus where there could be gaps and opportunities for improvement. First and foremost, have you reduced the scheduling process to writing, a standard operating procedure, a decision tree, whatever works for your organization? Who does it? What questions to ask? Scripting is a great thing to make sure you ask all the right questions during that scheduling process so you don't miss any critical information that may help determine whether telehealth is appropriate, in-person is appropriate, information that's critical to have in the system to make sure the service could ultimately be billed and paid if it's a covered service. Do you have a feedback loop if somewhere subsequent to the scheduling process, maybe an error or a gap was identified for a particular patient? A lot of times those schedulers aren't going to know that they're missing something or that there was an error unless there's a feedback loop. That may be something as simple as a typo in putting the patient's member ID into the system, or could be something more significant, like not getting the insurance at all, or that the patient was actually out of network when they thought they were in network, or something along those lines. But that feedback loop at any point in the process is really important to help improve each step of the process. Do you have a sort of decision tree for the schedulers, as typically non-clinicians, to have a sense of what is appropriate via telehealth versus what needs to be in person? Or if you have this process available online, maybe there's a decision tree that the patient can walk through and click, is it a runny nose? Is it cough? Is it some of these more acute symptoms? If not, then maybe an in-person visit. It routes them to the in-person visit scheduling process. So next step in the process, the patient checks into your office, checks into your facility, or logs into the system if we're talking about a telehealth service. Great point in time to have a double check. You can never check the insurance and the coverage too often, particularly if we're talking about end of the year when open enrollment is happening. Patients may be changing their health plan, beginning of the year when health plans may be changing. The first time the patient's being seen in that year, it never hurts to check again and just make sure you've got the right insurance company, you've got the correct member ID, you've got the correct name and number, subscriber, address to send the claim to, etc. Verify the patient's location. We may have asked that during scheduling and the patient says, yeah, I'll be located in Kansas, but lo and behold, they're calling from the grocery store parking lot in Missouri at the time of the visit. That may impact whether the professional rendering that telehealth service is licensed in the state where the patient is located at the time the service is rendered. We'll talk about it at the rendering the service stage, but documenting the patient's location in the note as well is a best practice to make sure that that the provider's licensed and we've got the patient's location at the time of service. Verifying patient identification and having that as part of the initial scripting at the check-in or the login phase is also really important. There is an increase in medical identity theft where patients may say, oh, to my sister, I've got an appointment tomorrow, you can use it. They'll never know that it's you versus me. So verifying whether it's two forms of ID through visual and matching that with a photo of the patient in your system, but trying to verify that you are talking to the person you think you're talking to, whose demographic information you've collected and whose insurance you may be billing for. If you've sent out any pre-appointment paperwork to the patient, new patients, established patients that you need to renew or refresh their information. I've seen this information go out to collect social determinants of health information, changes in their medical history or medications, making sure that you've got that completed prior to beginning the appointment or walk through that with the patient and complete it at that time. So then we move to the step of actually rendering the service, right? When we're talking about telehealth, rendering the service is often done through an audio, visual, real-time, two-way communication like we're having today. You can see me, you can hear me in real time, you could turn off your mic and talk with me in real time. However, we know that a lot of times the video connection may be poor. Molly was mentioning right before the session started that there was some audio cutting in and out. So if you're having technological issues, if the patient cannot connect via video, chooses not to connect via video, or whatever the circumstances are, document that in the note as well. This was an audio visual telehealth service. This was audio only because, and that will help for a couple of reasons. Document the format of the telehealth service, which may dictate whether or not the service can be paid based on the way it was delivered. Documenting the patient's location. I've mentioned that a couple of times now. A couple of things about the patient's location. Not only the state that they're located in, that helps for licensing rules to make sure the provider who's creating the note, rendering the service, signing the note, and billing for the visit is licensed in the state where the patient was located at the time of service, but also location in the sense of, is the patient at home? Are you rendering a telehealth service to a patient who is in another provider's office, in a retail clinic? Wherever the patient is located, the type of setting is what I mean by documenting the patient's location as well. Documenting any consent. Now, this may have happened in your pre-appointment paperwork, general consent to treat, but during the visit, you may discuss things like care management, transitional care management, chronic care management. Maybe you talk about remote patient monitoring, things that the patient may be receiving that are not necessarily face-to-face services, and we need to get consent from the patient to participate in those. Consent to participate in care management service doesn't necessarily require a written signed consent. Verbal consent is okay, but documenting that you've gotten that consent. Also may be a great time to reiterate, if we haven't already gotten it prior to the service, the patient's consent to have a telehealth service. A lot of times, rather than the provider asking this question and documenting the patient's response, I typically see this as sort of almost like a pop-up or click-through as the patient is logging into the telehealth visit. A consent that says something along the lines of, you're about to participate in an audio visual telehealth service, talks about maybe the privacy of the visit, the confidentiality of the visit, security risks, but the patient agrees to proceed with the visit anyways. And if you're doing it in that way, kind of a click through, when the patient clicks, somewhere on the back end, the fact that the patient has clicked and agreed or e-signed that consent should be recorded and available somewhere in the patient's medical record. Documenting the duration of service. So not only the content of the visit, which is always important, but particularly in telehealth visits, especially in audio only visits, documenting the duration can be particularly helpful to support the code or codes that you end up assigning and billing to a health plan, if applicable. Now, I will also say that in 2023, there were some changes to the evaluation and management service guidelines, and E&M codes are often the types of codes that you're reporting for these telehealth visits. Among the changes were an expansion of the types of activities that can count towards the time that a provider uses to select the level of service. So if you haven't already, take a look at those expanded list of activities that the provider can count in the duration of time, including documenting the service later on that day. Create the note timely. I would say create and authenticate, create and sign the note timely. So we want to see that it's being created timely. Medicare, I would say WPS Medicare, which I think is all three of our states, MAC, clarifies on a website that generally that would be about 48 hours from the date of service that the note is created and authenticated and signed off on. Beyond that short time frame, we may start to have some challenges with late entries or untimely documentation that could create challenges if there was an audit of the services. So as quickly as possible after the service is rendered, we want it documented and signed. When we authenticate the note, we want to make sure we're following all applicable signature requirements, even if that's an electronic signature. Medicare has, I think, 5 or 6 pages long of instructions on what they consider to be a valid signature. In each of your individual states, professional license rules may have guidelines on what qualifies as an appropriate signature, as well as plans having signature requirements. In general, what you want in a valid signature is the provider's name, their credentials like MD, DO, physical therapy, etc., the date and the time of the signature.
Rochelle?
Yes.
We did have a question in the chat regarding provider location and probably related to documentation as well. So the question was, I know that the patient must be in the state in which the provider is licensed, but does it matter where the provider is actually located?
That's a great question. I didn't address the flip side of that, so thank you for asking that question. It does, in a sense, matter, typically not from a licensing perspective. Most states, from a licensing perspective, say that the provider has to be licensed in the state where the patient is located, not necessarily the state where the provider is located. If that's a temporary location, like the provider's on vacation or they're at a conference, yet they're having a telehealth service from another state, that typically is not going to affect the licensure rules, but it may affect the practice location that is reported on the claim form. So that is an important consideration to think about. Most payers' instructions, and Medicare included, say that if this is just a temporary location for a day or two, a conference, a vacation, that you would report the provider's normal practice location in, I want to say it's box 32 or 33 of the claim form or its electronic equivalent. However, if this is a practice location where the provider typically renders service from, that's not the clinic, the hospital, or their normal practice location, that should be reported as the location of service on the claim form. And after the PHE ends, beginning May 12th, you need to enroll that location under Section 4 of the provider's 855 enrollment with Medicare, and may need to undergo similar credentialing and enrollment updates with your other payers and plans to say the provider's home or their winter location in Arizona or Florida is a practice location. So yes, document that and make sure you're following any payer enrollment criteria to make sure that address will be covered and is appropriately identified on the claim form when appropriate, when necessary, I should say. Great question. Okay, so still talking about this stage of actually rendering the service, and some questions you can ask or take back to look at your current process. These are where things can fall through the cracks. We can miss charges or have some pitfalls. This used to be the missing ticket report. Probably goes by different names now, but I think of this as we had a list of appointments, and then we had those physical tickets, those physical charge sheets that the patient took to the checkout desk in the clinic setting, and that was what was used to enter the charges into the system. So I've always called this a missing ticket report, but it's basically when we have an appointment and we have no corresponding charges for that appointment. That might be a missing ticket, an indication that we might miss charges for that particular visit. Now, if it turns out that a visit is non-billable for one reason or another, that can happen for a lot of reasons. Maybe this is a routine post-op appointment that is within the global period of a procedure, and so we don't bill charges for that post-op visit. You can still enter, sometimes it's a dummy code, sometimes it's a 99024. There may be a way to enter something into your system to tie it to that appointment, even if it doesn't go to a health plan, or even if the charges are zero, or sometimes you've got to put in 1 cent or $1 if the system doesn't accept zero, just to reconcile that something has been entered and accounted for that visit with the patient. Do you run, or I should start with, do you have the ability to, and if you do you run unsigned note reports? Generally, we don't want the charges to go out until the notes are signed, indicating they are finished, they're complete, and they're accurate. So if we have unsigned notes that are out there lingering that haven't been signed off on, we may be missing charges. And if that goes on for a long period of time, we may have timely filing issues. We may have issues on whether we could bill the service at all, depending on how long we were waiting for that provider's signature to take place, and if that's outside the reasonableness of the time frame to document the services. Is there a coverage policy for any of the services that have been provided, or a frequency limit for those services? Wellness visits, tobacco use cessation counseling, alcohol screening, depression screening, substance use disorder screening. Those types of things may have not only frequency limits, but maybe condition limits. The patient only qualifies to have that service covered if they have certain diagnoses. So in those types of instances, if a coverage policy applies, we may want or need to provide an advanced beneficiary notice for a Medicare beneficiary or a similar financial responsibility document for other payers during that visit. There may be other special forms. That's one example, but maybe a school, a child school assessment form, the medical form from Medicaid that needs to go to daycare or needs to go to the school. Particular forms that may be required for the Medicaid HCY wellness and preventive screening visits. If this is a visit where there's counseling for potential sterilization procedure, there are specific consent forms that may need to be completed at that time. So are there other special forms other than the progress note that need to be completed and included as part of the record for that visit?
I have a clarification for the licensure location. So does the provider location for enrollment need to be included by the time the PHE ends, or is it at the end of the calendar year 2023?
That's a great question. I'll double check on this. My recollection, the most recent guidance was when the PHE ends, meaning May 12th, that means that the provider's practice locations do need to be enrolled with Medicare again. There are some caveats. Again, if it's just a short-term infrequent location, like I'm at a conference this week, I will never be, that's not somewhere I'm routinely providing services from. That doesn't need to be enrolled as a practice location. But if the professional routinely provides telehealth services from their home, for example, that may need to be enrolled as a practice location depending on how frequently that occurs. And that needs to be done by May 12th. I'll double check that and I'll provide the resource after this session. But the most recent update I saw was that's the day of the PHE and not the end of the calendar year. Get that note down for a follow-up. Thank you for that question. So on the charge capture stage, this is a really critical piece to the sustainability of telehealth programs into the revenue cycle. We can do all the right things up until this stage, but if we don't capture the charges and get them entered into the system and get them billed and hopefully get them paid, we're not going to have a sustainable program. So take a look at the way your system works now. What you do in the charge capture phase may vary depending on whether your system automatically captures charges, meaning it can look at a note and it can identify based on orders and orders that have been completed that an evaluation and management service has been rendered. If time's being documented, maybe it can capture prolonged service codes and time. If these are provider selected, provider documents the note and identifies this is my level of service. I also did these screening items that might be additional charges or prolonged services. Or do you have coders or other team members that manually capture the services that have been provided to enter them into a billing system? Whichever process is happening, and maybe it's a combination of the three, there's lots of opportunities for gaps or missing charges, and always opportunity to go back and spot check periodically when we may be missing charges. So I'll give you some examples of charges that are commonly missed and ways that you could go back and spot check when you potentially have rendered these services and could have potentially missed the opportunity for charges. Advanced care planning has a CPT code in the CPT book. It's something that generally can separately be reported from an evaluation and management service on underlying issues. When it's performed and when it's documented, we would look to see if there is the sufficient amount of time spent in advanced care planning to support reporting that visit separately. Sometimes we may have a preventive wellness service in conjunction with a problem-oriented evaluation and management service. Those could potentially be separately reportable on the same day for the same patient. Alcohol, depression screening, tobacco use cessation counseling, Medicare annual wellness visits or the initial initial preventive physical exam, the IPPE, when the patient first enrolls in Medicare. Prolonged services that extend a considerable portion beyond a considerable amount of time beyond the standard time for the base evaluation and management service. Appropriately distinguishing between a new patient versus an established patient, and so on. So let me go through a couple of these examples. A preventive with a problem-oriented visit. One way you could go back and spot check when we could potentially have missed charges for 2 E&Ms, a preventive and a problem-oriented visit for the same patient on the same day, is to look at the diagnosis codes that are on the visit or that are entered into charges. Preventive visits typically have a Z code, a Z diagnosis code associated with them. And there's a range of codes for those preventive or wellness visits. If we run a report or if we look at an account that has that Z code, and only a procedure code that describes a problem-oriented visit, like 99201 through 99215. We could go back and into the note to see, was there a separately identifiable preventive visit that was performed because we have a Z code describing a preventive visit, where we might have missed those charges. And if we find that we have, in some instances, missed that, what are some steps you could put in place to prevent that from happening and to make sure you're capturing those charges appropriately? The same thing for alcohol or depression screening. If the patient has a diagnosis code for alcohol use disorder, alcohol abuse, has depression, anxiety, or other mental behavioral health conditions, those diagnosis codes might prompt us to go into the note. Did we do a screening for alcohol use or misuse? Depression screening, a PHQ-2 or PHQ-9 or other depression screening. If we did and the documentation supports it, we might have missed the opportunity to bill for those charges. Or we may need to educate the provider on, additional documentation elements to capture and support those charges for billing. I want to look at these last two, new versus established patients. There are some changes in the CPT book and Medicare guidelines for this year, but I think this is really important to think about in your practices, how you can evaluate provider specialties to accurately optimize when a patient is considered a new patient versus an established patient. In the CPT book, a patient is a new patient if they have not seen that exact same provider or another provider of the exact same specialty and subspecialty within the last 3 years. So the provider's specialty and subspecialty designations become really important for deciding whether a patient is new or established. Whether a patient is new or established is important because new patient visits tend to have a higher weight and a higher rate of reimbursement than an established patient. So when you look at providers and their NPI taxonomy, their primary taxonomy and their subspecialty taxonomy, and the way that they are credentialed with the payers, make sure that is as accurate and as specific as possible to their particular practice area. I was working on this with an orthopedic group, and there are lots of subspecialty designations in orthopedics and orthopedic surgery. And whether they're hand surgeons, foot and ankle, whether they typically do major joint replacement, whether they do rehabilitative medicine, and those are all subspecialties. So within an orthopedic practice, a patient who once saw a hand surgeon and is now seeing a foot and ankle surgeon, while those all fall under the umbrella of orthopedic surgery, if those subspecialties are appropriately designated, that patient could still be a new patient, even in the same group practice within 3 years, as they see providers of different subspecialties. Now, Medicare does not recognize subspecialties. So it's also very important for Medicare on the provider's 855 enrollment to make sure their primary specialty designation is as accurate as possible. There's family medicine, I believe there's geriatric medicine, internal medicine, making sure those designations are appropriate, because a patient who sees a primary medicine, a primary family medicine provider and an internal medicine provider in the same group practice in 3 years could still be a new patient with internal med because it's a different primary specialty. So looking at your specialty designations from an NPI perspective, Medicare enrollment perspective, and commercial payer credentialing perspective can be a really important exercise to make sure you are capturing new patient charges appropriately. So we get the charge capture, that's kind of the body of services that we may be able to bill for. And then there's the billing entry stage, taking those possible charges and actually entering them in a way that is consistent with coding guidelines, payer policy, any editing or bundling rules that may apply to that encounter. So we want to make sure, of course, they get entered. How do they get entered? How do we make sure they're all in there? Some common points of error in this step could be entering the wrong CPT code. And I'll give you an example of that. If I go back one slide here and we look at alcohol screening, depression screening, tobacco use cessation screening, wellness visits. Those are services that payers like Medicare may have their own unique codes for, like HCPCS codes that start with the letter G, that they want reported for their particular program, but that may also have comparable CPT codes. And if we're not entering the right code for the right service for the right payer, we're going to see denials or incorrect reimbursement for those services. Entering the wrong diagnosis code. There's two places that we have to worry about this in charge entry, making sure we get all of the diagnoses for the patient for that visit entered that meet the definition of a first listed or principal diagnosis and secondary or additional diagnoses in accordance with coding guidelines. Okay, so there's sort of the universe of all the diagnoses that were evaluated or treated during that visit, but also on a service specific or line item specific level, we link that service to the diagnoses that apply to that particular service and in order, meaning diagnosis number one that we put on the claim might be a Z code for a preventive visit. But if a particular line item is for a problem-oriented evaluation and management service, I want to point to a different diagnosis as my first listed reason for that particular service. That might be diagnosis code number 2 on the claim, which could be diabetes or hypertension. And we want the diagnoses that we are pointing to on a line item level to make sense for that particular service. If there's not a covered diagnosis, did we get an advanced beneficiary notice or comparable patient financial responsibility? That impacts modifiers that we may need to apply on a line item level. Had a clinic at one point that was transposing numbers on a diagnosis code that they were entering and was billing for 80061, I think, is a lipid profile lab test, and linking it to, I want to say, impacted earwax as the diagnosis instead of the code for hyperlipidemia. So you can create edits in your system too if you're commonly mislinking services and diagnoses. An edit or an alert that says, hang on a second, is this the diagnosis code you really meant to link to this service because it doesn't make sense, or this is not typically a diagnosis code that would be reported for that item. It allows you to correct it before the claim goes out, helping ensure you get paid accurately without rejections, without denials, faster, and avoid the time and the resources to rework those rejections and denials and get the claim out the door. Making sure we've got the right units of service, if this is a time-based code and the time is listed in the CPT code, is that time a threshold, meaning we have to reach that time as a minimum before we can report the service? Or is this something where the midpoint rule applies? As long as we pass the midpoint for the time listed for that code, we can report the service. Units of service in the sense of dosage for injections that might be administered, Or if this is a therapy code reported in 15-minute increments, have we captured all of those increments? Payer policies can differ on time-based reporting too. Anesthesia time reporting varies widely across payers. It's often reported in 15-minute increments, but 15 minutes might mean 8 minutes for some payers. It might mean 10 minutes for other payers. It might mean a full 15 minutes for other payers. Making sure we've got all the right modifiers on a line item basis. Some common ones you may think about: modifier 25, if we have multiple evaluation and management services, or E&Ms with other item and services like an annual wellness visit or a depression screening, may require a modifier 25 on the office visit or other E&M code. Modifier 24 is a routine post-op visit in the global period of a procedure. So if the provider, the surgeon, is seeing the patient via telehealth or in person within 10 or 90 days of a procedure, that might need to have a modifier 24 added to say that this post-op visit was distinct and separately identifiable from the procedure that the patient is within the global. I've seen that when the patient's having complications, although Medicare doesn't pay for complications separately in the post-op period. I've seen it when a patient had a surgery on the right shoulder, but this post-op visit within 90 days of the first surgery is coming in for an evaluation of the other shoulder. And so that is it's separate from the reason for the initial surgery. Modifier 57 is a visit where the decision for a major surgery was made the day before or day of the major procedure. 59 might be a distinct procedure or service, two things that typically aren't reported together, but under the circumstances are appropriate to report. And we add a 59 to the less extensive procedure that would normally bundle into the payment for the more comprehensive primary procedure. And that modifier tells the payer, hey, I know these two things typically don't go together, but it's appropriate in this instance, and this is why. 95 is a telehealth service modifier, one that we're using right now, but we won't be using as much, depending on the payer, once the PHE ends and we go back to using place of service 0, 2, or 10 for a telehealth service. FS is a telehealth service modifier that indicates that the supervision requirements have been met through virtual supervision. A cost sharing modifier, modifier 93, that the telehealth service was rendered as an audio only, not audio visual telehealth service. We want to make sure we get the correct supervising provider on the claim. The provider, if it's not personally rendered by that provider, but incident to or under their supervision, Medicare rules say the provider that was there actually rendering the direct supervision is the one that needs to be listed as the supervising provider that day, which may be different than the provider whose services a telehealth visit may be incident to. So Dr. Smith sees the patient, says, follow up next week with my nurse for a blood pressure check. Nurse follows up for a blood pressure check, but Dr. Smith's out of the office. Dr. Jones is in the office directly supervising the nurse that day. Dr. Jones is the supervising provider for that service. This is the next element. It's a great question to piggyback on the clarification that was asked about the distant site provider's location and the billing locality where the professional component of a service is rendered needs to be where the distant site provider is located. So in our Kansas, Missouri area, where we're right on the state line, for example, Kansas is a different locality for Medicare billing than Missouri is. And Missouri has 3 different localities throughout the state to be submitted to Medicare. And Medicare has a whole detailed manual. If anyone's interested, I'll be happy to send it out as a resource that define when you bill the professional and technical components separately and how you define the locality that the professional component is being rendered from.
Really quickly, Richelle, I just want to make a fast announcement. We have about 5 minutes left of our time, but if you're able to stay on and go over a little bit, that's great. But just remember, we will be sending out these slides that will have these check marks on them and these checklists that you can run through. And we'll also be providing a video link. And then one comment related to the previous slide with billing entry was also to make sure you have the patient name correct. Sometimes first, middle, and last name and initials can be the same as other patients. And I'm assuming that's one reason why date of birth can be very important to ensure as you're doing the billing entry for the patient.
Absolutely. And making sure that it's exactly as it appears on their insurance ID card is great, because John may go by Johnny, Jonathan, and a different number of names. And to get it into the payer's adjudication system, it needs to match what's on their insurance card, because that's what the payer is going to have in their system. If there is an error, and I've had this happen before, where the payer had the wrong date of birth for the patient, and so it was causing the claim to reject, then the payer is not receiving that claim, and it can have an impact on whether you have timely filed your claim, because it's never received by the payer. And happy to talk through how to handle some of those challenges if you've ever had them. At the rejection and denial stage, you need to make sure you're working your rejections promptly. And that kind of piggybacks on that comment, because a rejection coming back from the clearinghouse has never made it to the payer's system. So in terms of timely filing that go by the payer's date of receipt, the payer has not received those claims that have been rejected at the clearinghouse level. So you've got to work them, get them corrected, and get them resubmitted to preserve your timely filing with the payer. If you get denials from insurance companies, I strongly encourage you to enter the denials and the denial reason codes into your billing system. This is such valuable information about the reason claims are being denied, to not only help you internally, do we have typos at the insurance identification process or date of birth? Are we not getting modifiers on claim? Are there coding issues? Whatever those denial reasons are will really help you with your internal process to improve, prevent denials, get paid faster. But it also may be telling that there could be an error on the payer's claims processing system, that you need to reach out to your provider representative and say, hey, something's not processing correctly here. Can you take a look at this? And when you're tracking those denial reason codes, it really helps you run those reports and look for trends by reason code, by payer, by reason code, to improve your processes and get paid faster and more accurately. When you find by running those reports, if there are things that are preventable, like a lipid profile being billed with the diagnosis code of impacted earwax, you may be able to put steps in place in your system to automatically prevent those claims from going out the door. An alert that says, Richelle, I don't think you entered the diagnosis code for this procedure correctly. And it's a prompt that can be corrected right then and there to avoid the multi-day or week or month delay that may otherwise occur if that were to go out and get rejected or get denied and has to come back, and we expend resources working that denial. If you get a denial, don't just take that as the final truth, that it is what it is and you didn't get paid. Do you agree with the denial? If you don't agree, appeal. Look at your contract and look at your appeal options with a particular payer. We could have a whole session on how to handle those processes, but use the appeal process if you don't agree with the payer's decision. And then finally, payment posting. Did you get paid what you expected and when you expected it? Most states, Kansas, Missouri, Oklahoma, have prompt payment rules, so that if your claim was clean when it went out the door to the payer, no errors or defects, no additional information needed to adjudicate that claim, and you weren't paid timely, that's 30 to 45 days typically, depending on the state, the payer is supposed to add interest onto their payment if they were late getting the payment back to you. Did you get paid the amount that you would expect in terms of your contract? If not, why or why not? If you got paid for the allowable, look at the reason codes. Was it because this is being passed on to member responsibility? Is there some other reason, like multiple procedure reductions, bundling edits? And again, if the payment amount's not what you expect, don't necessarily take that as it is what it is. Is that consistent with your contract and with the payer policies? And then finally, patient responsibility. Do you have a mechanism to get patient statements out timely? There's nothing more frustrating as a patient. We probably all know this as a patient and as providers when we've been working through the insurance process for months and months and months, and the patient doesn't get their statement for a year or more sometimes, or we weren't running statements on a regular basis. We didn't have a set schedule. So once every 9 months, we run a bulk batch of statements and get them out to the patient. Are you sending statements and bills to patients in a way that they are the most likely to respond to? Snail mail, hard copy mail may not be the best way to send those to patients anymore. I love getting links to bills on my cell phone that I can quickly log on, pay, and get taken care of on the fly wherever I am, or by email, or other mechanisms, depending on who your patients are. What's the best way to get those? Do you have policies for writing off bad debt, sending accounts to collections, how many efforts you will take before you write an account off, charity care, financial hardship, small balance write-offs, or prompt payment for self-pay patients where you might discount your charges a little bit? And then I know we're 2 minutes past time, so I'll just quickly address some common key performance indicators. If you get to this stage and you want to start monitoring how you're doing on these different phases, some commonly recommended KPIs for the revenue cycle, just to get you started as some basics, might be understanding your payer mix, right? Of the total universe of claims you go out, what % are Medicare, Medicare Advantage, Medicaid, Medicaid MCO, commercial payers? A lot of providers break out Blue Cross or United, the major player in your market, as kind of its own category. Exchange products, whatever that is, have that payer mix in mind. Wrong payer rejections, indicating that we didn't get the insurance updated at that scheduling or check-in or login process, and we need to have a feedback loop to do a better job at that preliminary stage. Initial versus final denial rates. Initial denial rates can indicate maybe we didn't get charges entered correctly, or we had some data entry, some coding or billing issues. It could also mean that there were issues on the payer end, not processing the claim correctly. Often we have a large initial denial rate, but we work those accounts if we're working them well and timely, and we can appeal or correct claims and resubmit claims, that our final denial rate is much, much, much less. And that will tell us not only that we should have been paid in the first place and we can correct some things on the front end, but also tell us how well we're doing working those denials rather than just writing them off and losing the revenue. On the facility side, a DNFB, discharged from the facility but not final billed yet, would be comparable in the outpatient or ambulatory setting as how many days from the date of encounter to the date the claim goes out the door. What's that time frame typically? We want that to be as short as possible. We want claims going out so we can get paid promptly and as quickly as possible for those services. And then how long are our claims sitting in AR? That could be an indication in part of how well we're working our AR, rejections and denials and appeals. It could also be an indication of our payers not paying timely, where we may have some mechanisms that we need to communicate with the payers as well. I went 4 minutes over, but hopefully that's some helpful items to look at, different steps in the process, and some practical checkbox items that you can take away to see how you're doing and where you may have opportunities for improvement.
Thank you very much, Richelle. I will just add that some of the notes I took during your presentation include feedback loops across all patient points of contact. So schedule to check-in to the visit to billing. Are there missed charges? Are you missing signatures? Do you have all the documentation that you need? Does everybody have a list of telehealth qualified visits that could be converted to telehealth, and all those things like that? So when we send the follow-up email, you'll have the presentation, and really try to pay attention to those check boxes too, because those give really good notes on all of those steps involved in evaluating your billing process. There are some things in the chat box I've noted, and I will get with Richelle on that. So you should have some links and resources included with the follow-up email that we'll be sending out later this week. If you have any questions, you can email us at htrc@kumc.edu. And thank you for coming.